of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, we have got two guest speakers. We have our national guest speaker, Dr. Rajesh Sawant from Mumbai, and our international guest speaker, Dr. Richard R. Gammon from Orlando, Florida. Our first guest speaker, Dr. Rajesh Sawant from Mumbai, is going to lecture us on fine-tuning of platelet transfusions in 2024. And followed by your international guest speaker, Dr. Richard R. Gammon from Orlando, Florida, speaking to us on the importance of ABO in platelet refractoriness, an often overlooked option. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Rajesh Sawant and Dr. Richard R. Gammon, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 10th of November 2024 from 11:30 a.m. Indian Standard Time, you Dr. Maria Victoria Matthews from Spain speaking to us on managing multiple myeloma in 2024, what is new. Let me introduce our discussants for the day, and here displayed in alphabetical order. To start with, we have Dr. Aditi Jain from VMMC and SJH New Delhi, Dr. Aditya Jandial from Homi Bhabha Cancer Hospital and Research Center, Mulirpur, Punjab, Dr. Alka Khadwal from PGI Chandigarh, Dr. Amrita Chakrabarti from Max Hospital, Delhi, Dr. Chandra Vishwanathan from Mumbai, Dr. Deepesh Lad from Vancouver, Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, Dr. Joyce Regi from Sir H.N. Reliance Foundation Hospital, Mumbai, Dr. Krutika Kurhade from Max Super Specialty Hospital, Chandigarh, Colonel Dr. Kundan Mishra from Kaman Hospital, Lucknow, Dr. Meena Verma from BLK Max Super Specialty Hospital, Delhi, Dr. Mithu Shrikhande from Fortis Hospital, New Delhi, Dr. Nilesh Jain from Balco Medical Center, Raipur, Dr. Nidhi Mehta from A Super Specialty Hospital, Mumbai, Dr. Pooja Prasad from Homi Bhabha Cancer Hospital and Research Center, Punjab, Dr. Rohit Jain from Jaipur, Dr. Vipul Sheth from RGCIRC, Delhi. And now is to introduce our first guest speaker for the day. We have with us Dr. Rajesh Sawant from Mumbai. Dr. Rajesh Sawant is consultant at the Department of Transfusion Medicine at KD Ambani Hospital, Andheri, Mumbai. He was given the responsibility of setting up the Department of Transfusion Medicine at ATTRACT, that is Tata Memorial Center, Kharghar, which was licensed by the FDA and is functional since 15th August 2005. Since then, the Department of Transfusion Medicine has been continually striving to maintain high-quality standards for provision of safe blood in adequate quantities to meet the needs of patients admitted at ATTRACT, as well as other hospitals and nursing homes in Navi Mumbai. Actively participated as faculty during the training program of NECO, organized by Ministry of Health and Family Welfare, Government of India, at Department of Transfusion Medicine, TMH, for the training of doctors, technicians, and nurses from 106 blood banks in Maharashtra and Goa. He was also the honorary transfusion medicine expert on advisory board of the Maharashtra State Board of Technical Education for the postgraduate diploma in blood bank technology and management. He was also invited as transfusion medicine expert for external audit of Department of Transfusion Medicine, Dr. MGR Medical University, Chennai by NACO. He was also commissioned transfusion services like PBRSC Harvest, bone marrow harvest, cryopreservation protocol, therapeutic leukapheresis procedures, flow cytometry, etc. required for BMT unit at ATTRACT. In 2012, he contributed immensely towards setting up of the state-of-art Lifeblood Center at Rajkot, Gujarat, which eventually happened to receive the ISBT Institutional Award in the year 2020. He also worked in collaboration with the GSCBT and IMA Gujarat State for conducting awareness programs for clinicians regarding safe and appropriate blood component transfusion. He also spearheaded the NABH accreditation of the Blood Center at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute in 2021. He was also qualified as technical assessor for NABL for immunohematology and HCIG sections. Currently, he is a principal assessor for NABH transfusion services and have contributed towards assessment of about 35 blood centers for effective implementation of quality systems. He is also the member secretary of Hospital Ethics Committee since 6 years. And today he is going to lecture us on fine-tuning of platelet transfusions in 2024. Well, thank you so much. I stop over here. Over to you, Dr. Rajesh Rawat.
Well, thank you really for that very elaborate introduction, and a very good evening, afternoon, morning to all those who have joined us today here. And what I'll do quickly is share the slides so that we can start the talk. Are the slides visible now?
Very clear, sir. Please go ahead.
Okay, great. So friends, what I'm going to do in the next, say 30 to 35 minutes is talk about fine-tuning platelet transfusions in 2024. Though the title may suggest that this is something like, uh, recent advance or things like that, but I am going to talk about or reiterate rather the few important basics that are still lacking in certain clinical practices or in ordering practices, etc. So the slides won't progress. Yeah. Okay. So this is the basic outline of the talk. Basically, we will look at certain technical aspects like preparation and administration, bedside administration of the platelets. Then we will talk about evidence-based practices for platelet transfusion therapy, which would include prophylactic platelet transfusions versus therapeutic platelet transfusions. We'll also talk about a few tricky perioperative indications for platelets. Also, we will look at the risks of platelet transfusions as well. So to begin with, I think all of us know the basic that platelets are manufactured in the factory known as the bone marrow. And we have these platelets, about 70% of them in the circulation, which also 30% are stored in the spleen. So that is the splenic reserve. And we have, all of us know about the thrombopoietin mechanism, which controls the production of platelets. And these platelets, once they are aged or they are disrupted, they are destroyed or removed from the circulation through the reticuloendothelial system. Now, certain important aspects which we need to know, the basics about platelets, say platelet anatomy or immunology. The first important thing is human platelet antigens or platelet specific antigens. They are present on the platelet surface and they are very polymorphic in nature. And these can stimulate the production of alloantibodies. And therefore, patients we say who are alloimmunized or who have platelet alloimmunization may have antibodies against either the human platelet antigen or the HLA antigen. So I'll talk about that also a little later. But when human platelet antigens are involved, the commonest complication that we see is neonatal alloimmune thrombocytopenia and post-transfusion purpura. These two clinical scenarios where the patient may develop refractoriness to infusion of donor platelets. The next is about the HLA antigen. So class 1 HLA antigens are present on the platelet surface. Class 2 are absent. So here what happens is that the white blood cells, the leukocytes, which express both the class 1 as well as the class 2, which are invariably present in all the components that we prepare and we transfuse to our patients. So these leukocytes in conjunction with the class 1 HLA antigens on the platelets will lead to formation of anti-HLA antibodies, both class 1 as well as class 2. And that is in fact 70 to 80%, the reason for antibody mediated or alloimmunization to platelet transfusion. So therefore, leukodepletion is of paramount importance, especially for those who are likely to receive platelet transfusions on a repeated basis. The next important aspect is about the ABH antigen. I'll not go into the details because my fellow speaker is going to cover this very elaborately today, but we all should know that ABH antigens are expressed on platelets to a greater or a lesser extent. And we also should be aware of certain individuals who have high titer of anti-A or anti-B isoagglutinins in O group donors or recipients. So that is something to keep in mind. And these high expressors for ABH antigens, these platelets can be actually destroyed very fast in circulation, especially if your recipient is having a high titer of anti-A or anti-B isoagglutinins. Now let us come to the next important aspect. How do we prepare these platelets? So there are various methodologies that are available. You have the PRP method, that is the platelet rich plasma method, where the blood, whole blood that is derived from a voluntary donor, it may be 350 ml or 450 ml in Indian scenario, which is collected in citrate anticoagulant, and it is kept on hold at room temperature for about an hour. And within about 6 hours of its collection, the blood is centrifuged at a slow spin and the PRP is separated into the attached empty satellite bag. And this again is now centrifuged with a fast spin and separated into 1 unit of platelet concentrate and 1 unit of plasma. So a random donor platelet or a whole blood derived platelet, as it is popularly known as, will contain about 5.5 into 10 to the power 10 platelets, and the volume would be about 50 to 70 ml if it is prepared from a 450 ml blood donation unit. The other method is the buffy coat method. So over here, what we do is the buffy coat portion of the donated blood, it is spun and the platelets are separated from the buffy coat. There is also a methodology of pooling the various buffy coats from 4, 5 or 6 units and then preparing buffy coat pooled platelets also. And this has been recently, a couple of years back, licensed by the FDA in India. Previously, pooling was not licensed by the FDA in India. So buffy coat method has its own advantages again. And so these were all whole blood derived platelet preparation methods. If you need single donor platelets, then you have apheresis platelet donation. So there are various cell separator devices, which I'm sure all of you must be well versed with, which are manufactured by 3 to 4 major manufacturers worldwide. And these devices may be working on the principle of either a intermittent flow centrifugation principle or a continuous flow centrifugation principle. So in intermittent flow centrifugation, what happens is that there is a draw cycle and there is a harvest of the component, that is platelets, and after the harvest is done there is a return cycle. So this happens cyclically 8 to 10 to 12 times depending upon what are the parameters that we have set, and the platelet single donor apheresis platelet is prepared. Whereas the newer generation of these cell separators, in which there is nothing like a draw or a return, the draw and the return happens simultaneously, and therefore these are a little more quicker than the previous generation cell separators. But in general, most of these cell separators will at least yield us about 3 into 10 to the power 11 platelets in a single unit, which is equivalent to about 4 to 6 whole blood derived platelets. So that's how we equate the random donor platelets with the single donor platelets. So this is how these platelets look. This is a apheresis platelet and this is a random donor platelet. And then you also have pooled platelets, which can be prepared by pooling the platelet rich, the PRP method platelets, or you can pool the buffy coats, as I said, and prepare pooled buffy coat derived platelets. Now, when it comes to, the choice of platelet component, in many countries, there is still a lot of myth around apheresis platelets or single donor platelets. Clinicians and even the general public, patients, families, many times feel that apheresis platelets are much superior than random donor or whole blood derived platelets. So let us look at three such myths. The first myth is that apheresis platelets should be used for patients who are not demonstrating a good post-transfusion platelet increment. So if the counts are not increasing, switch over to apheresis platelets. But the fact is that there is no benefit from giving randomly selected apheresis platelets in cases who are truly alloimmunized. In those cases, you will have to give either cross-match compatible platelets, or matched platelets, HLA matched platelets, right? The other myth is that apheresis platelets are a better component than pooled platelets and should be held as stock. Whereas if you look at the fact, there is no published evidence as yet that apheresis platelets are superior in various aspects compared to the pooled leukodepleted platelets. The third myth is about apheresis platelets cause fewer allergic reactions. So these are generally viewed to be safer. There would not be much of allergic reactions and various other transfusion reactions. Well, again, here the evidence is that apheresis platelets are likely to cause more allergic reactions, because if at all any such implicated substance will be present in a whole blood derived platelet, it would be in a smaller quantity, whereas in the apheresis platelets, it would be in a larger quantity compared to the whole blood derived platelets. So with this, let us also talk about platelet additive solution, or PAS as it is generally called. So platelet additive solution, like we have additive solutions for our red cell, function maintenance and maintaining its storage qualities. We have platelet additive solution also now. So generally, it will reduce the amount of plasma that is transfused along with the platelets, because about 70% of the plasma is removed and it is replaced by the platelet additive solution. It will also avoid the transfusion of large volume of plasmas and avoid adverse reactions like cardiac overload in patients who are prone to circulatory overload. And the third important benefit is that it is making photochemical treatment or pathogen inactivation much efficient for platelets. And lastly, it improves the storage condition of platelets because it provides a good nutrition medium and a good environment for the platelet to be stored for 5 days. So if you look at the composition of these currently used platelet additive solutions, they have sodium chloride, potassium chloride, magnesium chloride, sodium citrate, and various other buffers like sodium biphosphate and sodium acetate, etc., in different quantities. So here the $1 million question is that, fine, you are using platelet additive solutions, you are getting rid of 70% of the plasma that's there. And therefore, now are you going to be worried about the group of the platelet? May it be whole blood derived or pooled or apheresis platelet. So this is one of the studies that we did. Can platelets with PAS be considered safe for transfusion to recipients of any blood group? So can we use it as a universal product, non-blood group specific? So here there were 167 platelet concentrates, where 79 were pooled platelets and 88 were apheresis derived platelets, which were studied. And what we did is we performed IgM and IgG isoagglutinin titers on these platelet units before addition of platelet additive solution and after addition of platelet additive solution. And you can see that the titer, it was reduced by at least twofold because of the addition of the platelet additive solution. So based upon our findings in this particular pilot study, we could conclude that platelets with additive solution can be considered safe for transfusion to recipients of any blood group. However, there is one word of caution there. If the baseline titer is above 512, then you have to be cautious, because even after the platelet additive solution is introduced into that unit, the residual titer can be above 128, and that can lead to positive DAT. So you have to be cautious in those who have a higher titer than 512. So what we need to work towards today is understand better ways to store platelets. So three major points I would highlight over here. One is that the activation of platelets during collection, preparation, storage, etc. should be prevented to the least possible, to a very low level. So that means you should have very, very robust SOPs for collection of platelets, for their transport, for their storage, etc., for their monitoring. The second aspect is that the level of glycolytic activity, the anaerobic consumption of glucose and production of lactate should be kept to the minimum possible. And third is that at least some glucose should be present in the platelet concentrates throughout the whole storage period so that their pH is maintained below 6.2. Right. So these are the most important aspects we take care of during the storage. So let us look at the regulatory requirements for storage, transport, and expiration. So the storage temperature, unlike other blood components, is air conditioned room temperature 20 to 24 degrees Celsius, and during transport also it has to be maintained at the same temperature as far as possible. And the expiration time, date or time for platelets is only 5 days in our country, and in some of the Western countries where they do bacterial culture on each and every platelet unit, it can be extended to 7 days if the culture result is negative. If by any chance it becomes an open system, then we have to use it within 4 hours for transfusion. And yes, there is also a very, very frequently asked query is that if by any chance there is mechanical failure to agitate, the platelet agitator is not working, then what do you do? So how long can you accept platelets stored without agitation? Yes, you can accept them if it is without agitation up to 24 hours, right? So this is something which we need to know. Now let us talk about certain manipulations of platelet component that are possible and that are done on a day-to-day basis. So first is volume reduction and platelet washing. So at times, as I said, transfusion associated cardiac overload can be a problem. The other challenge is that O group, which is the most prevalent in many countries, including India, these individuals may have high titer of anti-A or anti-B, and therefore you need to remove at least 70% of the supernatant plasma. You may or may not have platelet additive solution, in which case there is possibility that about 15% of your platelet component may be lost. So you have to bear that in mind, but volume reduction is basically done for reducing the volume, of course, and also for increasing or enhancing the safety of those platelets. Platelet washing is indicated in very, very special situations. So it is not all that commonly done when the recipient is allergic to certain proteins that may be coming through the plasma that is there in the platelet component, or the recipient, he or she may be already immunized to those proteins, or there is IgA deficiency in the recipient, and therefore he may develop a anaphylactic reaction to various plasma proteins. So here you may lose up to about 29-30% of the product while washing. Washing can be done as a closed system and also as a open system. If it is done in an open system, please transfuse it as early as possible or within 4 hours of preparation. The other important aspect we need to know about is the red cell content. So since platelets are derived from whole blood, the random donor platelets, and also apheresis platelets also have minute quantities of red cells in them. So we need to know what is the permissible level of red cells. So permissible level is about 0.5 ml of red cells per unit of the platelet. And we also need to know what is the reported immunizing single dose. So the immunizing single dose is about 0.03 ml. So that's the least volume of red cells that has been found to actually lead to alloimmunization to the red cells, right? And the cumulative dose is 0.05 milliliters. So whenever a Rh negative individual receives a Rh positive platelet in adults or in men, it may not cause any problem at all. But when it is a child or a woman of childbearing potential, then you have to consider giving immune prophylaxis by ROGAM or anti-D immunoglobulin. Next, coming to gamma irradiation, as we all know that leukocytes may lead to various complications, including graft versus host disease, and leukocytes are present in a good number in platelet component, and therefore gamma irradiation is indicated. So, in fact, it is simpler to irradiate platelets because unlike red cells, the platelets morphology or any of its surface topography is not affected by gamma irradiation using 25 gray dose, and therefore you can in fact irradiate all the platelets which are available in the inventory. We do follow that, and of course please remember that this irradiation does not take care of any viral inactivation or anything like that. So platelets can just be irradiated and stored for their complete shelf life of 5 days. Now, the most important concern is how safe are these platelets? So if you look at the transfusion risk related to platelets, about 1 in 20 chance that the recipient may have a febrile non-hemolytic transfusion reaction, 1 in 100 chance that there might be a minor allergic reaction, and there would be a 1 in 10,000 chance that there could be complications like TRALI and symptomatic bacterial sepsis. So we have to be aware of these 3 or 4 important complications. So I would put sepsis on the forefront, followed by hypotensive reactions, TRALI, allergic reactions, and then FNHTR, and rarer complications like GVHD, HLA alloimmunization, and various other viral transfusion transmitted infections. So to take care of this today, something which we read in our textbooks about 2 decades back, we have now in reality pathogen reduction technology is available in various formats. And here I've shown the example of one of the products, which is Mirasol. So here you can use the pathogen reduction technology after the preparation of the platelet component and actually take care of all the possible pathogens, including viruses, bacteria, etc., in those platelets. Cost, of course, can be challenging, but yes, slowly but surely, I think the cost would come down. Next important practical aspect is administration of platelets to the recipients. So here we should remember that platelets have to be administered through a standard component administration set, that is a standard BT set, which has the filter of 170 to 260 microns. But do not use your micro aggregate filters of 20 micron to 40 micron size, because they will lead to uh, platelet entanglement in the filters and activation of the platelets, and the transfusion will not be complete. Also, along with that, we have to remember that warming of platelets is not really indicated. Like we have blood warming devices, automated blood warmers, etc. But platelets generally should not be warmed. And the other important aspect is about using a platelet leukoreduction filter. So instead of using a bedside filter, it is always better to do the filtration for leukodepletion in the blood bank laboratory. So with this background, now let us quickly go over to the clinical aspects. So few important considerations when you are thinking of platelet component transfusion in your patients. The first is effect of storage time on clinical efficacy. Now, it's a general belief, many a times, I'm sure all of you must have faced this, that you have issued a day 5 platelet and it is returned back by the resident doctor saying that, it is very near expiry. Or sometimes, even the family members may not accept transfusion of such platelets. So is that really a problem? Say, suppose there is a day 4 or day 5 platelet unit, is there a problem? Will it really have a lower quality, statistically significant lower quality? So there are various studies which have looked at clinical response to single donor platelets, which was measured at 15 minutes and 24 hours in form of corrected count increment. And they found that there was no association between corrected count increment and storage time. That means even day 1 and day 5 platelets worked equally. So there was no significant relationship between the age of the unit of platelets and the interval between transfusions. Next, let us look at the duration of platelet storage and development of transfusion reactions. This is another myth generally, that if it is day 4 or day 5, there will be definitely a transfusion reaction. So what does literature show us? That transfusion reactions may not have an adverse impact on the effectiveness of platelet transfusion. That is one. And the chance of bacterial infections, if at all there is bacterial contamination, then that increases over a period of time, whereas no other transfusion reaction like allergic reaction, etc., will increase. The chances of these will not increase with the storage period of the platelets. As far as ABO compatibility is concerned, we are going to hear from the next speaker, so I will not go much into the details of this, but as I already mentioned, that there would be about 30% of individuals who would be high expressors of A and B antigen on the platelets, and their platelets, if they are transfused to non ABO compatible recipient, then they can be actually removed from circulation a little bit early than the compatible platelets. So that's something we need to remember. So there would be a reduced or decreased platelet recovery in those cases. Next, let us look at the effect of reduced storage volume of platelets. So volume reduction, we talked about that. So what happens with volume reduction is that there is increased lactate accumulation, the pH will decrease, and that can lead to platelet activation. Therefore, volume reduction has to be done just prior to issue of platelets. Once you do the volume plasma depletion, volume reduction, transfuse your platelets within 6 to 8 hours. That's what is recommended. So with this, we come to various guidelines. Now, these are the various guidelines that really are a good source of reference for various clinical scenarios. So there are guidelines by the American Association, the AABB also, and we'll come to various other guidelines also later. Now, this is a very interesting topic because platelet transfusions, apart from the hemat-onc patients, came into the forefront with dengue in the last 1 decade. And in fact, this was one of the newspaper article where random platelet transfusion is killing patients. This was a report that was published in one of the newspapers in Mumbai. And based on this background, I share our data where we had a uniform protocol defined for dispensing platelets to rationalize platelet transfusion therapy in for dengue patients in our hospital. So there was this uniform protocol for dispensing platelets, which was defined by the Municipal Corporation of Greater Mumbai, and this was introduced in the year 2016. So in the pre-implementation phase, before this intervention was implemented, platelets were given as the clinician or the ICU in charge requested them. Whereas in the post-implementation phase, we spoke to the ordering physician and discussed with them about the threshold involved and various other aspects of platelet transfusion. And you can see the difference over here in terms of the number of platelets that were transfused were significantly lesser, statistically significantly lesser, even for random as well as single donor platelets. And the transfusion threshold, in fact, reduced from about 27,000 to 18,000. So it was now closer to 20,000 and towards 10,000 instead of about 20,000 threshold. The other important aspect which I wish to highlight over here is about bacterial contamination of platelets, and that is actually a reality. Many a times such appearance of platelets is just dismissed like a fibrin clot or things like that, because whatever the mind doesn't know, the eyes may not be able to identify or see. So this is our data of bacterial contamination. So as a part of our College of American Pathologists accreditation requirement, we perform bacterial detection for all the platelet components that are prepared. So this is one of our data of the last year, where about 9,952 platelets were tested, and of which about 1/3 were with platelet additive solution and without platelet additive solution, and 2/3 were with platelet additive solution. And you can see positive culture. This includes the initial positive result also. was in 4 cases without platelet additive solution and in 19 cases with platelet additive solution. Now the difference over here is because platelet additive solution, in fact, it facilitates early detection of bacteria if at all they are present. So that is the benefit that we derived out of use of the platelet additive solution. One more noteworthy thing over here is that only one out of these 19 initial reactive bacterial detection tests was confirmed reactive. So that is something which we have to really work upon, and world over this has been reported, and therefore there is a lot of debate going upon what is the best strategy to sample. Can you do a large volume delayed sampling at say 36 hours of storage or later, or even up to 48 hours of storage and later, or is your primary culture at about 24 hours as a single culture going to be working fine? So currently we are following the third strategy, that is primary culture at 24 hours as a single culture. So this is something which we have to think about, but yes, bacterial contamination is a reality and we need to look at it properly. Next, we come to platelet dose. So as we all know, platelets, a random donor platelet will have about 5.5 into 10 to the power 11, and a single donor platelet will have about 3 into 10 to the power 11 platelets, right? Random donor platelet will have 10 to the power 10 platelets. So 5 to 6 random donor platelets will be equivalent to one single donor platelet. So when we transfuse these platelets to an adult, we expect that the count will be increased by 30,000 to 50,000, right? So roughly we know the dosage of platelets, but can we calculate it? Yes. So the dose of platelets can be calculated using this formula, that the platelet dose in 10 to the power 11 should be the target platelet increment that you want to have multiplied by the blood volume, and there is a multiplication factor of 1.5, and divide this figure by 100. So 1.5 is the correction factor here for splenic uptake here, right? So with this, the platelet dose, how it is important, this is the summary of the data that is being published on by Norol et al. Way back in 1998. So if you look at their dosage pattern, they have platelets of medium dose, high dose, and very high dose. Medium dose is 4 to 6 into 10 to the power 11. High dose is 6 to 8 in 10 to the power 11. And very high dose is greater than 8 into 10 to the power 11. Now, if you look at the increment, they have also proportionately increased with the dose. But what is very significantly important here is the transfusion-free interval. You can see that with the very high dose, the transfusion-free interval was about 4 days. So, which is a very good interval, and therefore if you have a good dose of platelets and if you know that the patient is going to require platelets on a regular basis, give them a good dose. Whereas for the standard indications for platelet transfusion, even the medium dose works fine. So when we are talking about dosage, we need to know about the effectiveness of platelets, which can be calculated using the corrected count increment, which can be calculated by post-transfusion minus pre-transfusion platelet count multiplied by body surface area and divided by number of platelets that were transfused and multiplied by 100. So you can calculate this CCI at 1 hour and at 24 hours after the transfusion. So if your 1 hour increment is affected, is low, that means when will you call it low? When it is less than 7,500. So generally 1 hour CCI has to be at least 7,500 and the 24-hour CCI has to be at least 4,500. So 1 hour CCI is affected if the patient has undergone a splenectomy or prior BMT or DIC or received certain medications like amphotericin B or has a HLA antibody. Whereas 24-hour CCI will be affected if there is any clinical bleeding, fever, antibiotics, or any platelet-specific antibodies, etc. Apart from CCI, you can also calculate one more parameter that is known as percent platelet recovery, which can be calculated by multiplying the total blood volume into the platelet count increment divided by the number of platelets transfused, and this will give you the percentage of platelets that were recovered in the circulation of the patient. So like this is an example where you can see that the PPR was 41% over here. So this also gives us a good insight into what is happening into the circulation of the patient. Now let us come to the most debated topic is the thresholds. So before going to the thresholds, we need to understand that where is the cutoff? Like what is the risk of spontaneous hemorrhage? So if the count is above 40,000, then the risk of spontaneous hemorrhage is minimal almost everywhere except in the brain, right? With 20 to 40,000, you may be at a risk of GI mucosal bleeding. With a count of 50 to 25 to 20,000, you may have skin petechial hemorrhages and mucous membrane bleeding also. And when a count is less than 5,000, the most dreaded complication of CNS bleeding or bleeding in the lungs, alveolar hemorrhage, is what is to be kept in mind. So our approach to a thrombocytopenic patient should include, first is rule out pseudothrombocytopenia and then look at three different possibilities. Look for whether there is any sequestration. So look for splenomegaly, or there is any reduced production. So look at the bone marrow investigations, or look for any causes of increased destruction. So these are the three approaches to a thrombocytopenia case, right? So here history goes a long way. Look for any history of bleeding and various other secondary illnesses like neoplasms, etc., or any medication history, any infection like HIV, etc., any familial history. Look at the CBC. Don't forget to ask for the platelet function test also. So all these investigations will help us in evaluating the bleeding patient, right? So platelet concentrates are definitely indicated in certain congenital conditions like Glanzmann's or Bernard-Soulier or gray platelet syndrome, etc., and also post-CABG or uremic patients, right? Also, acquired thrombocytopenia with platelet survival will be there in cases associated with bleeding like patients of ITP or drug-induced thrombocytopenias or patients who have thrombotic thrombocytopenic purpura, DIC, etc. So we have to bear these things in mind. So uh, till recent years, we looked at the figure of 20,000 as the threshold for platelet transfusion for prevention of spontaneous bleeding. But various guidelines have now recommended counts to avoid bleeding. So a count of 1 lakh for major abdominal, chest or neurosurgical patients. A count of 50,000 is good for trauma or major surgery cases. A count of 30,000 is good for minor surgical procedures. A count of 20,000 for prevention or treatment of bleeding in patients with sepsis, leukemia or malignancy. Up to 10,000 for uncomplicated leukemia and malignancy. And for ITP or other patients who are at low risk of bleeding, you can even wait till a count as low as 5,000, right? So there are various guidelines. I may not be able to go into the details of every guideline, but the ASCO guideline is available, the American Society of Clinical Oncology, where they say that even for a stable BMT recipient, you can wait till a count of 10,000. And also there are various other guidelines which guide us that for major invasive procedures, a count of 40 to 50,000 is okay. For lumbar puncture, a count as low as 20,000 is also fine. For a liver biopsy, 50,000, and for GI endoscopy, 20,000. So these are the recommended platelet counts for various interventions. Now, when it comes to prophylactic platelet transfusion, when it is count below 5,000, definitely always transfuse. If 5 to 10, if between 5 to 10,000 count, if the patient has fever or any minor bleeding, go ahead for a transfusion. If the count is between 11 to 20,000, if there is a coagulopathy accompanying this thrombocytopenia or there is any minor procedure planned, go ahead with the transfusion. But if the count is above 20,000, then only if there is a major bleed or any major invasive procedure, then go ahead with the transfusion. So here the new understanding is that instead of looking just at the count of 20,000 or 10,000, look at the trend of the platelet count. So if there is a rapidly falling platelet count, if there is profound fever, if there is proven infection, sepsis, and if there is GI or other mucosal ulceration, then you definitely consider transfusing platelets at whatever threshold it is. So don't go by the threshold in such cases. So instead of just looking at the counts, look at these clinical factors as well. So there are various such guidelines which have been provided by the NIH consensus conference conclusions, etc. So basically here we need to understand why not to transfuse, because there are a lot of risks that are associated with platelets, and you may not have substantial advantage of transfusing platelets like we saw in the dengue case, in the dengue scenario also. Moreover, platelet transfusions are expensive, and it can really cause a lot of stress onto the hospital or the even the transfusion services supplies, right? Another clinical scenario is when antiplatelet therapy is ongoing and the patient has to undergo surgery. So perioperative management, here there is a good guideline from the American College of Chest Physicians who say that if the patient is on clopidogrel, it should be discontinued for 5 days before the surgery, who are at high risk for cardiac events, and for 7 to 10 days in patients who are at low risk. But during this period, aspirin should be continued. So that is what is the guideline. For neonatal cases, these again can be tricky. So you need not panic if the platelet count is in the range of say 20 to 30,000. But otherwise it's a full term neonate or infant. But if it is a preterm with birth weight less than 1000 grams, that is 1 kg, then you have to, and if there is active bleeding, you have to transfuse even at counts less than 1 lakh. So 50,000 to 1 lakh can be considered as a threshold for transfusion in these cases. Now coming to adjuvant therapies or adjunctive therapies for bleeding cases, not only platelets, but fresh frozen plasma, cryoprecipitate, epsilon amino caproic acid, or various other recombinant human factors like Novo7, etc., need to be considered. Especially what we see during routine practice is that the physician, they quite often ask for platelets, but they forget to correct the coagulopathy. So FFP cryoprecipitate is omitted from the order. So these are the things we need to look at. And also various other management strategies like splenectomy or intravenous anti-D injections, etc., for certain cases, or using the alternatives, the pharmacological alternatives to allogenic transfusions, etc., need to be considered in these cases. Along with this, let us also understand which are the inappropriate indications or rather contraindications to platelet transfusion. So the first and foremost is thrombocytopenic, thrombotic thrombocytopenic purpura and various other microangiopathies. The next is heparin-induced thrombocytopenia, except in life-saving, life-threatening bleeding. Autoimmune thrombocytopenia, again, if there is threatening bleeding, go ahead, otherwise don't transfuse. Chronic DIC in the absence of bleeding, or prophylaxis during extracorporeal circulation. These days we do a lot of ECMO, etc. So prophylactically you need not prescribe platelet transfusion. Similarly, prophylactically during massive transfusion, it's not needed. You can follow the 1:1:1 protocol. And in cases of post-transfusion purpura. So if you look at data, so this is one of our local data where just by doing a platelet transfusion audit, we could, bring down the inappropriate use of platelet concentrates, which was, patients getting platelet transfusion above 20,000 count were 80% in the pre-audit period, and it could be brought down to about 56% in the post-audit period. So simple audits, they really help us a lot. But these also have to be done in a cautious way. So what needs to be in place is a good transfusion policy, which includes specialist unit policies, basically, like we saw just now. You can't have a general policy. There has to be a policy for cardiac patients, for hem-onc patients, for pediatric patients, for neonates, for obstetric, for trauma, etc. And generally, the transfusion medicine consultant should be involved if more than one adult therapeutic dose is requested. So audit of every request which is more than one adult therapeutic dose is something which helps a lot. And also looking at the hematology results and other biochemistry results and all other telltale signs of hemolysis will help us. So the key aspects over here is that you need to control by auditing, but the control needs to be subtle. Very, very important, right? Otherwise it may misfire. And information, good history, good sharing of information, filling up the proper request is very, very important. And having a good dialogue with your clinician colleagues is very, very important. Involving them in your protocols is going to be very important. And I think empowering our own transfusion medicine laboratory staff for auditing these requests is going to help us the long way, to prevent inappropriate transfusions. Also, hospital transfusion committee plays a major role in regularizing the transfusion policies as well as procedures. So according to me, the physicians play a major role in ordering the proper transfusions, the proper component in the proper dose, right? So, and also recognition of any possible life-threatening transfusion reaction. So a lot of role is played by the physician in ensuring a rational transfusion of platelets. So I would say that platelet transfusions is the cornerstone of supportive therapy for patients with hemorrhage, and they should be administered to maximize their benefits and minimize the risk. And I think finally, our thrombocytopenic patients, they definitely deserve nothing lesser than the best. So summarizing, I think I would say that very few platelets are required to maintain endothelial integrity. So use them judiciously. Proper dose of platelet transfusions need to be looked at. Reduce the number of platelets transfused. Use single donor platelets for the appropriate indications. Collaborate closely with your treating physicians, your colleagues, and use technology if that is available for preventing or early diagnosis of your HLA antibodies or platelet alloimmunization, etc. These are a few important references. And that's it really. Thank you very much. Thank you organizers for giving me this opportunity. And thank you all those who have joined us today on a Saturday evening. Thank you so much. And I would be happy to take questions.
Thank you, Dr. Rajesh Rawat, for that wonderful talk. Fantastic. I think you covered almost everything from top to bottom regarding the platelet transfusion. Some couple of questions to you before
Sure.
the ball keeps on rolling. Regarding chronic bone marrow failure syndromes, uh, who have got aplastic anemia from long period of time, maintaining platelet count less than 10,000, and they have developed platelet alloimmunization. What should be your target goal for platelet transfusion in those patients?
Well, generally, we have seen that these patients, they are tuned to be okay even with platelet counts as low as 20,000 or so. So if they are afebrile, if they are not taking any other medications, etc., then we really do not transfuse them at counts above 20,000. We wait and watch, keep platelets on standby, but we avoid the transfusion. The second important aspect, recently in the last 2 years, we've seen that there is a facility of platelet cross-matching is available currently. So, if you have a pool of say 10 donors and you cross-match them with the patient, and you know that which donors are the best suited for the patient, and you repeat those donors constantly. So minimizing donor exposure is something that has helped us, and which, you achieve a good corrected count increment with those donors. So doing your CCIs and having a good donor pool, a repeat donor pool, helps in these cases.
Thank you, sir. Another question from Dr. Amber. He says that he usually doesn't get increment in platelet count even in patients who are getting them for first time in bone marrow transplant patients. What could be the reason?
Well, no platelet count at all can be, I mean, it needs to be investigated really. So generally when we approach a case where there has been little to no platelet increment at all, what we look at is right from the preparation to the storage to the bedside administration. And many a times we have seen that simple things like bedside administration was not proper, or microaggregate filter was used in some cases where most of the platelets were lost, in the transit from the BT set to the patient's vein itself. So certain such things, or concurrent administration of various other intravenous medications sometimes. So a lot of nurses training related elements are involved in non-increment of platelets. If we look at other causes like refractoriness or alloimmunization, as I already touched upon, we should rule out fever or various other medications or hypersplenism, etc. And the increment definitely should be there, right? Also speak to your transfusion provider, because they will have the data of the platelet content of the platelet unit, and based on that you can also have a calculated increment.
True.
Hi, sir. I had a question.
Yeah,
Yes,
and Dr. Kritika, I will come to you. I'll
Okay.
just finish up the question. He says that basically if the patient do not have any increment during the bone marrow transplant, so during that procedure, that becomes a very risky situation sometimes. So what can be done in those patients? What type of platelets can be given to those patients?
Well, more than the type of patients, basically here it is very important to deliver a good dose of platelets, basically. So in the early post-infusion phase, when the bone marrow, is still engrafting, the stem cells are still engrafting. In that phase, we've seen that a cutoff threshold of up to 10,000 also works fine if the patient is afebrile. If there's sepsis, of course, we transfuse at 20,000 or so. But with constant support and taking care of sepsis, I think, and once the engraftment happens, the patient regains the platelet count.
So in such scenario, when the platelet increment is not happening, can we go for IVIG?
Yes, if it is refractory to any platelet transfusions, then
Yes.
definitely IVIG is used.
Thank you. Uh, Another question he has is if the patient has got a platelet count of just 4,000 to 5,000 and no bleeding in a case of bone marrow transplant patients, and the patients they fail to recover their platelets by platelet transfusion, what can be done? Should we keep it as low as 4,000, 5,000? That would be enough, or should we go on repeated platelet transfusions at the count of just 5,000, and
Uh,
the patient has no bleeding?
Yeah, so if the patient is clinically okay, 5,000 has been, recommended as the threshold, but it can be dangerous. So having platelets on standby is very, very important in that case, because if the patient becomes febrile or so, these patients may have CNS bleed at any point of time. So we have to maintain on the safer side a count of at least 10,000 in afebrile patients. So that's very important. And if you have the facility of platelet cross matching, and in certain instances, so these patients may be already alloimmunized. Out of our own experience, like while I was working in Tata Hospital, once we had done just a primary screening of all those patients who, attended the BMT OPD in the evaluation phase, and we found that more than 35% of them already had anti-HLA antibodies, because they received transfusion outside which was non-leukocyte depleted, and they already had anti-HLA antibodies. So when they go up for a bone marrow transplant, they definitely would face challenges related to thrombocytopenia, not maintaining the platelet count, etc. So in such cases, there are various modalities that are available. First, you give a trial of the same blood group platelet and a good dose, maybe possibly a double dose, and fresher platelets, etc. If that also does not work, then you look for antiplatelet and anti-HLA antibodies, and then a therapeutic plasma exchange session based on the levels of the anti-HLA antibodies definitely helps. So, we in fact do that as a basic protocol only when we work up our patients and we find them to be positive for anti-HLA antibodies.
Thank you. Dr. Kritika, your question.
Hi, sir. So, I'm a pediatric oncologist in Max Chandigarh. Here we have a common practice of giving irradiated platelets to all our neutropenic patients. But I just heard you mention that it does not really protect them from any infections.
Correct.
Right. So then, is this practice just the idea that we have that we need to irradiate platelets before giving to all neutropenic patients to protect them from infection is just not really the right logic behind it.
Absolutely. I mean, thank you for asking this question. So the commonest misconcept I've seen, whenever we talk to our clinical colleagues, is that they feel that if gamma irradiation is done, it has taken care of everything, bacteria and viruses and WBCs and everything. So that's not
Correct.
the case, actually. It just inactivates the proliferative capability of the T lymphocytes, nothing else at all. Even the antigens remain intact. So a gamma irradiated platelet unit can still lead to HLA alloimmunization because the HLA class 1, class 2 antigens are still,
Correct. Correct.
you know.
Right.
So you need to filter. So leukodepletion cannot be replaced by gamma irradiation. Many clinicians ask us this question. So we've irradiated. So do we need to still filter? But yes, you need to filter. And
Okay. Thank you.
yeah, so blood banks do the platelet irradiation basically because it does not cause any lesion. Like in red cells, it will lead to hyperkalemia and hemolysis, irradiating.
Correct.
You don't
Correct.
irradiate and keep red cells, but platelets are absolutely fine. So it makes sense that you irradiate your entire inventory and keep it and issue it, whether the patient requires irradiation or not, but still you can issue that as a safer product. But it does
Okay.
not really work for neutropenic sepsis.
Thank you. Thank you, sir.
Thank you, Dr. Kritika. Dr. Vishwanathan, your question, please.
Yeah, good evening, Dr. Sawant. It was a nice
Good evening,
presentation. I
ma'am.
think you've covered everything very well. Two unconnected question. One is, of course, I was excited to hear about the Mirasol, which we have been hearing for more than 2 or 3 decades. I'm happy that
Absolutely.
it has already come up. What is the financial implication and whether it is available to all corporate hospitals? That's one question. And with all the therapies that are going on today, I'm sure there'll be so many of them in your hands, which are, HLA antibody developed already or HPA developed, etc. So you're going to have a big database you will develop. How cumbersome it is, and who can access it? And a little word about that.
Sure. The first question was about Mirasol or
Yeah.
any pathogen reduction methodology. So yes, there are various pathogen reduction methodologies available, especially for plasma and a few for platelets. For red cells or for whole blood, currently it is still in phase 3 clinical trial stage. As far as cost is concerned, it can cost anywhere between, say, 3,500 to 5,000 per unit. So it is
Oh,
quite costly currently. The
okay.
cost needs to really come down for it to be implemented throughout that ways.
Hmm.
But the technology is now available. Even the FDA has taken due cognizance of pathogen reduction methodology and it is available. So there are a few hospitals, in fact, government hospitals and all have also done that for a select, group of patients. Like, for example, some hospitals do it for all their transplant patients. Some of them do it for their liver transplant patients and
Okay.
things
Okay.
like that, that way. As far as HLA alloimmunization and platelet refractoriness is concerned, no, we don't have uh, a resource or a library of such donors
Okay.
who are HPA typed or anything like
Okay.
that. In fact, we are somewhere midway doing this for our red cell, phenotyped donors. So for that, luckily, many blood centers now, at least in many cities of India, they do have at least donors in, say, hundreds or even in thousands for some common antigens who have been phenotyped. But for this, it is not possible. So the only approach that we have is you can maybe, and then cost, of course, again, of
Yeah. Yeah.
HPV
Yeah.
being and all. So you can just type the family member, or even without doing the typing, you know that they would be haplo-matched. So in case of emergencies, you extract or harvest the platelets from one of the siblings and use them after gamma irradiation in a patient who is not at all responding to any platelet transfusion.
Okay.
And that has really been life-saving actually for patients.
Okay. Thank you. And if I may be allowed to ask one more question,
Sure.
you didn't touch
Sure.
on cryopreserved platelets or frozen,
Oh,
whichever platelet,
yes,
because
yes,
that
yeah,
has been
thank
a
you. So,
research. So I
yeah,
thought you
in
didn't
fact,
touch on it. I wanted, because there are some students I'm sure are listening to our talk.
right,
So
right.
that's all.
So, in fact, there are quite a few such areas which, I could not keep in the scope of
Okay.
this particular talk because there would be,
That's okay.
yeah, you will have platelet gel, which is also available, like fibrin sealant, platelet gel, and PRP is used therapeutically also. Cryopreserved platelets, yes. So, these are in fact available, and they can be stored at -80 degrees for up to 1 year with a cryoprotectant, but the loss during storage is up to 40 to 50% of the platelet component. So for patients who have some antibodies against very common platelet antigens and all, this can be used. So they are available globally also. And now the recent trend is working towards cold stored platelets. So instead of storing them at 22 to 24 degrees Celsius, store them at colder temperatures, say 2 to 4 degrees Celsius, and see how their property is maintained. So that a lot of work is going on in that.
Thank you. Thank you so much. Thank you.
Thank you, thank you, ma'am. Dr. Alka, your question, please.
Good evening, Dr. Savan. It
Very
was
good.
a very, informative talk on platelet transfusion. So I had 2, 3 points. One of the point has been already taken, asked by Dr. Vishwanathan regarding this cold and cryopreserved platelet. The other two are very simple one. One was one of your slides you mentioned in the causes of decreased CCRI after 1 hour. There was a mention of splenomegaly. One of the cause was splenomegaly and another cause was splenectomy. So both are kind of opposite thing. So how can splenectomy cause decreased CCRI at 1 hour? That was one my confusion, which I just when I saw your slide. And the other is the other question is, if a patient is bleeding very heavily and very severely thrombocytopenic and is on the verge of hypertension, and the blood bank is ready with both products, RBCs as well as platelets. So, what would you suggest we should be transfusing first, RBCs or platelet? Because sometimes I read somewhere the rheology kind of thing happens in blood vessels. So first you should be giving RBCs, but then if patient is bleeding, we would like to give platelet first. So it's kind of choice. And what would you suggest?
Sure. Yeah. So the first thing about splenomegaly versus splenectomy. So splenomegaly, definitely hypersplenism can explain the increased
Yeah.
consumption of platelets and increased peripheral pooling of platelets, etc.
Yes.
Whereas splenectomy has been an observation that has been made. So in patients who do not have increments, very commonly the splenectomized patients for some reason have been found to be not incrementing well, after platelet transfusion that way. So that is an observation. The mechanism is not really very well defined, but it's an observation. There can be multifactorial, cause to that way. The second is about what to transfuse first. So I would say in such cases, so there are a lot of experiments and lot of massive transfusion trials that are going on, where this kind of debate that whether red cells and in what proportion, 1:1:1 or 1:2:2, etc. But uh, transfusing plasma, and especially if not plasma, then cryoprecipitate and platelets will help in kind of achieving some amount of hemostasis, and then you transfuse your red cells. Also, technically, if you see, red cell transfusion will take a little longer time, whereas plasma and platelets can be quickly pushed inside. So that is what would be recommended in such a case.
Thank you. Thank you. Thank you so much.
Thank you, Dr. Alka. So there are some questions from the audience. Dr. Touch Khanara wants to ask that for the patient who are on antiplatelet drugs and unfortunately need the urgent operation, that we cannot hold this drug urgently. Can platelet transfusion be used at this junction to avoid hemorrhage during the operation?
Well, platelet transfusion can be used. In fact, that is one of the most commonest reason in the surgical scenario where, we need to improvise upon. But then the platelets that are transfused will not be all that effective because already your antiplatelet drugs are in the circulation. So we have to understand the pharmacokinetics of these and the clearance times of these drugs that have been given. But yes, definitely under a cover of good dose of platelets, various interventions, procedures, etc. can be done.
Thank you, sir. Another question from Dr. Meena. How can HLA match platelets be prepared and how much time does it take?
Well, HLA matched platelets, actually for the preparation, if you know the HLA typing, it is absolutely the same like any other platelet preparation. But the most important challenge and the time consuming or the most important exercise is finding the HLA match. So having the matched donor available for which you need to do a high resolution typing of HLA of the patient as well as the donor, and then if they are matched, then you plan the harvest. So it's a big exercise basically. So if we have a larger database of HLA typed individuals, and if it is open to the public in our country, like it is there in many of the developed countries, only then we'll be able to contact a donor who is found to be matching exactly with the patient whom we are treating and request him to come down and donate platelets. But currently, we just approach the near and dear family members and do their HLA typing. And, or sometimes, as I said, we don't even do the HLA typing because you may not have time. That typing will also take at least a few hours or half a day or so. So you may go ahead with a family members donated platelets and just hope that because they are half matched with the patient, they may survive.
Thank you, sir. Another question from Dr. Sin Win. How many days does transfused platelets stay in the recipient's body?
So transfused platelets in the normal scenario would stay in the body depending upon, how old or what is their age, prior to transfusion. But in general, platelets remain in circulation for about 9 days is what has been reported. So there are various radio-labeled studies, isotope studies, etc., which have shown that they are on an average available for 9 days into circulation. So if we have had a storage period of say 4 days, then maybe 5 days after that, they will be there in the circulation, and after that they will be removed out of the circulation.
Another question from Dr. Sharifa. Sir, what's your opinion about request for irradiated blood products like PAC cells, platelet for solid organ transplant, example liver transplant?
Well, there is not an absolute indication for gamma irradiation currently, but it is under consideration. So there are many centers where, since it is an organ transplant and the recipient is going to be immunosuppressed to a great degree or so, they prescribe gamma irradiated components. But there are many other centers who currently are using gamma irradiated components only for the hematopoietic stem cell transplants and not for the renal or the liver transplant.
Thank you, sir. Another question from Dr. KK Radhika. How many times a platelet donor can undergo apheresis and at what intervals?
Well, a donor can donate platelets twice in a month. and 24 times in a year. That is the maximum in India as per our Drugs and Cosmetics Act. And between two donations, there has to be a gap of at least 48 hours. So various institutes, they have their own policy. So some institutes, they allow one donation in 1 week. And then the next week he can donate. And then there has to be 1 month's gap between the second and the third donation and things like that. But overall, you can donate 24 times in a year.
Thank you, sir. Another question from Dr. K.K. Radhika. Can we consider stem cell donor of a patient for platelet donation for the recipient?
Well, you can. In fact, in certain cases where there is nothing else to salvage, you can consider that donor for platelet donation also. Of course, it will be irradiated, so there shouldn't be any immunological or GVHD related challenges, etc. But you have to very closely look at the various antigens, HLA antigens, and possibility of what can go wrong, especially if it is not a fully matched donor recipient pair.
Dr. Alka, you have another question?
No, I also wanted to know about the same thing which Dr. Radhika has asked, whether we can use the same donor who is already HLA matched with the recipient for use, for getting platelets if the patient is not having, has not engrafted properly. The platelet engraftment has not occurred and he requires HLA matched platelet. So whether he can be used, and if that has been answered, the other thing is after peripheral stem donation, after how long a donor can again donate stem cell or platelets, maybe any component.
Yeah, so actually the guidelines related to repeat stem cell donations are a little varied. So there are countries where they allow stem cell donation only once in a lifetime. Whereas there are other countries who consider that a stem cell donation can be considered as equivalent to a blood donation for that matter, considering the red cell mass and other things, and there are, so if you look at the most common interval that has been recommended world over, it is an interval of 6 months. So after 6 months, you can be considered for donating, say, blood donation or another stem cell donation, etc. Whereas for platelet donation, even an interval of 1 to 2 months is considered as okay, because you don't really lose red cells during your platelet donation.
Yes, thank you.
Thank you, Dr. Alka. Another question from Dr. Gaurav Oja. After irradiation, can platelet be stored for how many days?
Again, thank you for asking this question. So the shelf life of platelets does not change after gamma irradiation. And that's why, as I mentioned, it is very convenient to irradiate all your platelets and keep, instead of irradiating every time when there is a request. So the turnaround time also is affected. So the platelet quality is not affected, neither is the shelf life reduced. Like in case of red cells, it comes down to 28 days or even 14 days, depending upon what guideline you follow. But for platelets, it still remains 5 days.
Perfect. Sir, can patient of primary polycythemia be a platelet donor?
No. So if it is a primary polycythemia, it is a deferral criteria for allogenic donation. So that donor won't be accepted.
And what about hemochromatosis?
Even that is not permitted. In certain Western countries, it is permitted based on certain other criteria, but in India, it is not. So though we may collect their blood as a therapeutic procedure, but that cannot be crossed over to a patient.
Perfect. Mr. Nikhil, has our international speaker joined?
No, sir.
Not joined. What should we do? Should we wait?
Well, We can wait for 5 minutes because it's already 8:20.
Yeah, because I've finished the question from the audience. Any discussion want to ask any other question to Dr. Rajesh Sawant? Yeah, Dr. Alka. Dr. Alka, you can go ahead. Dr. Alka, you have a question?
Oh, okay, my mic was off. So I just wanted to know whether we can use TEG and ROTAM based, whether we can make decision based on the TEG and ROTAM in our hematological patients, especially in bone marrow transplant patient for, I mean, assessing the need for platelets of the patient, though is non-bleeding and is not sick and is not having any fever, but counts are less than 5,000. So whether we should give prophylactic platelet to these patients or not, based on TEG and ROTAM.
That has not been extensively used for these patients, especially the BMT patients, etc. Whereas they've been extensively used in, say, bleeding patients with massive hemorrhage in the surgical setting, basically, more than the medical oncology setting. So, but yes, I mean, the popularity of these point of care tests now has led to a lot of innovations in terms of how they can be used for decision making, especially, say, right from the accident and emergency area to your bone marrow transplant unit and other places. So I think slowly we will have that data for reference.
Thank you.
Thank you. One question has come from Dr. Raghavendra Rajesh Warkar. Why is this range of 20 to 50 gray for platelet irradiation?
The
Why is the
25 grays. Okay.
Why is the range 20 gray to 50 gray for platelet
Okay.
irradiation? Why is
Yeah,
this
so
range?
basically this has been selected based upon the red cell survival characteristics, basically, because for platelets, this range does not cause much harm at all. But for the red cells, if it goes anywhere above 50, then there is bound to be a lot of hemolysis, profound hemolysis, and very excessive potassium efflux. These two complications do occur, and therefore it is safest to have the irradiation dose. The mean is 25. It should never be less than 15 grays, and it should never be above 50. So that is the range that we need to keep in mind.
So
The
it is
optimum is
15.
35.
So optimum is 35, minimum 15, maximum 50.
Yeah.
Another question is about pediatric platelet transfusion. In a case of neonatal alloimmune thrombocytopenia, how should the platelet be transfused?
Yeah, so NAIT, again, it is good to transfuse the mother's platelets, which can be washed and transfused to the baby. So that's the simplest thing that can be done, because again, like, we do not have any clue to particular antigen negative donors availability, etc. So it is always best that the mother's platelets can be washed and they can be transfused.
Is it commonly done that HPA-1A and 5B negative platelets be transfused in NAIT?
Yeah, but then again, the same thing, that at that moment you may not have the facility to do the platelet antigen typing.
True. So another question has come that what is blue light delivery platelet transfusion?
Sorry, what is?
Blue light delivery platelet transfusion.
Blue line.
Yeah, that's somebody has asked a question. Blue light delivery platelet transfusion. in a case of NAIT?
No, I did not get the question really.
So I think I also don't know what he or she means to say. It's a blue light delivery platelet transfusion in a case of NAIT. How it is being done?
Okay.
Fine. And so I think the questions are over. I think we have waited for the speaker. Mr. Nikhil, should we wait more or should we close the day?
Or we can close the day.
Okay. Dr. Alka, you had another question? Yeah, one more question has come. Again, a question from Dr. Gaurav Oja. After release of platelet from blood bank, within how many hours it should be transfused? I think that has
Well,
been
again,
answered.
yes, good. Again, platelet transfusion bedside administration is very important. And we have seen at places, instances where the 4-hour rule, which is applicable for red cells, the nurse feels that platelets also should go on for 4 hours. And once it is spiked, it becomes an open system and, an ideal place for bacteria to thrive and multiply. So the time that is recommended by guidelines is 30 minutes, not more than 30 minutes.
Thank you, sir. Another question from Dr. KK Radhika. What is the ideal filter to transfuse stem cell harvest?
What is ideal?
Filter.
Filter.
To transfuse the stem cells in the
The
patient.
standard BT set.
Okay.
Not any other, yeah.
So the standard BT set will do, sir. There won't be any problem with the infusion? Stem cell
No,
infusion?
there won't be, because microaggregate filters and all will lead to a lot of clogging and your cells will also get entangled in that. So a standard blood transfusion set is what is recommended for infusion of any of these PBSCs or bone marrow harvest, etc.
Thank you, sir. Well, so I finished all the question from the audience. Any other discussions wants to ask any other question? Well, so sir, thank you so much for that fantastic lecture.
Thank you for this opportunity.
Very crystal clear lecture and all the guidance was super, fantastic. What a lovely discussion, sir. Thank you so much.
Thank you, Dr. Amit. Thank you.
And I thank all our discussants and audience to join this meeting today and meet you tomorrow at sharp 11:30 a.m. with another webinar tomorrow. Thanks a lot. Goodbye for now.
Thank you, everyone. Thank you.
Thank you. Bye-bye.
Thank you. Bye.